Good evening, everyone, and welcome to the Connecticut Psychological Association's Social Justice Speaker Series. We are honored to have Dr. Helen Coons as our esteemed speaker tonight. The title of tonight's talk is Barriers to Breast Cancer Care Among Women in Underserved and Displaced Communities in the U.S. and globally, a social justice crisis. A warm welcome, Dr. Coons. My name is Shiva, and I'm the chair of the CPA Social Justice Committee. Joining me today are our dedicated social justice members, Beth, Kyler, Andrew, Lena, and Anne. Now I'm going to hand it over to Kyler to talk about our generous donors who support this vital work.
Thank you. So, the Social Justice Speaker Series acts as a catalyst for our shared goals of empowering ourselves, our clients, and the community we serve. And to sustain this important work, we rely on fundraising and the generosity of those who believe in the power of education and the awareness of our biases. We sincerely thank all donors moving forward and are truly grateful to our sponsors. Your support is the foundation that keeps the vital work alive and thriving. And so, as you can see on the slides here, we have a updated slide for 2026. And for $1,000 and up, you can see comprehensive neuropsychological services for the sixth consecutive year donating towards our cause and education, as well as the CPA Education Foundation for the fourth consecutive year. And as well as that, Stacy Tata has generously donated $5,000 to the SJSS in memory of her beloved parents, Dr. Jack K. Plummer and Lynn Tata Plummer. In addition, on behalf of the Planning Committee, we are thrilled that you could join us this evening, and we sincerely hope that you'll continue to attend our future speaker sessions. We are excited about Dr. Coons' presentation, and as a brief reminder, the CPA Social Justice Speaker Series offers free monthly meetings to CPA members, the wider Connecticut community, and our nationwide supporters. And I welcome you to our speaker series this evening. And with that, I'm going to hand it over to Lena to share our speaker's biography.
Hello, everyone. So, Helen L. Coons, PhD and American Board of Professional Psychology, is a board-certified clinical health psychologist who specializes in women's health and mental health, psychosocial oncology, and integrated care in women's health settings. Dr. Coons is currently president and clinical director of the Women's Mental Health Associates and Health Psychology Solutions in Denver, Colorado. Previously, she was a clinical professor in the director of psychology. And she also served as a clinical director while also being involved in the Women's Behavioral Health and Wellness Services, Adult Division, Department of Psychiatry, all in the University of Colorado School of Medicine. Dr. Coons has over 35 years of professional experience working with women with cancer, oncology healthcare providers, and the cancer advocacy community. She specializes in psychosocial aspects of cancer, such as preparing individuals and families for treatment procedures, survivorship issues, living well with uncertainty, cancer during and after pregnancy, moms with metastatic disease, sexual health in women with cancer, oncofertility, refugees and immigrants with cancer, as well as trauma-informed care in oncology settings. Known as a dynamic speaker, Dr. Coons presents to oncology teams and community audiences in the US and globally on psychosocial aspects of cancer and its treatments. She also consults at the national level on psychosocial oncology care and patient resources. Dr. Coons presented at the IOM National Cancer Policy Board meeting on psychosocial services needs among women with breast cancer, served on 4 of the Living Beyond Breast Cancer professional advocacy committees, contributed to Living Beyond Breast Cancer professional advisory committee. Contributed to a survey on advanced breast cancer for the oncology division, and currently sits on LBBC's medical advisory board. Dr. Coons is also a highly experienced content expert on psychosocial oncology for media writers, a fellow of the American Psychological Association. Dr. Coons is a former member on the board of directors of the APA, past president of the Society for Health Psychology, and the founding chair of the Leadership Institute for Women in Psychology. Dr. Coons received her PhD in clinical psychology from Temple University, Philadelphia, after completing her pre-doctoral internship in medical psychology, Duke University School of Medicine. She also completed the DHHS Healthcare Policy Fellowship. So now it is my distinct honor to invite Dr. Coons to guide us through what promises to be an insightful and inspiring presentation. Dr. Coons, the stage is yours.
Well, thank you so much, Dr. Stefano. And I want to first applaud the Connecticut Psychological Association for having such an impressive focus on social justice. I was speechless and certainly very honored when Dr. Clark reached out to me. And I really, we were talking before you all came on, I wish I could come every month. This is incredibly impressive. And I am really pleased, taken aback, and excited by your interest in talking about social justice issues as they relate to women in underserved communities, both in the United States and globally. I'm going to pull my slides up. Thank you so much for that very kind introduction. And let's, fingers crossed. And I'm thrilled to see so many familiar faces. And I'm also going to ask you all to stay online as much as possible because okay, I am older. I'm also like really get my juices going when I get to see my audience. And this is a powerful conversation in so many ways. Give me a second, fingers crossed. Okay, where did you go? Can you see my slides?
Yes.
Yep. Great. And unless you're cooking or eating or dealing with family or pets, feel free to keep your mic open. There'll be different times when we'll be asking some questions. So before I go any farther, I'm going to, when there's a break in the action, let me see if I can do it from here. I can't. This is a very powerful topic, as almost all social justice topics are. But this one affects many of us in different ways, and I'll be asking you all about that shortly. If after this program you need support, I'd like to invite you to reach out to me. I don't want to move to the chat, but I'm going to give you my cell. It is 215-370-2342. Maybe someone can put it in the chat for everyone. 215-370-2342. Right, that's a Philadelphia number where I lived for 25 years, although I live in sunny Denver, Colorado right now, which is markedly warmer than you're all about to be shortly. So I was asked to talk about barriers to breast cancer care among women in underserved and displaced communities in the US and globally. At that time, and I would still say, this is a social justice crisis. I will say this is a social justice imperative. You gathered that my primary clinical expertise across women's health, without a doubt, is in psychosocial oncology. I bet you could ask several colleagues across the country to substitute breast cancer for heart disease or any number of women's health issues. And the data would look pretty much the same when we look at underserved and displaced communities globally. But tonight we're going to talk about breast cancer. And I want to thank all of you for coming here. I also want to especially call out the individuals who identify as men. We don't often have men at presentations on breast cancer, and the majority of your patients are more likely to be women or women identified, and this issue will come up. Or when we talk about genes, your male patients carry genes for breast cancer as well. And we're going to talk about that, albeit I'm going to mostly talk about breast cancer in women or those who were biologically women assigned at birth. Also lovely to see some of my favorite colleagues online. All right, are we going to advance? All right, before we go any farther, I have no financial disclosures related to this presentation. This is the second time as a professional presenter, I've actually used generative AI as well as a very broad range of other national and global public resources to both obtain and verify presentation material. So, and I've put in the slide if I just happen to pull something from Google AI. Otherwise, I've used a lot of different references. This is the abstract that you're all familiar with. Let's bring this down to some individuals. Ms. D is a 67-year-old woman who was diagnosed with de novo metastatic breast cancer in Ukraine in 2024. De novo metastatic breast cancer means that her initial diagnosis was with stage 4 disease. Her treatment abruptly ended when her hospital was destroyed by a bomb. She experienced marked delay in her cancer care when she was evacuated from her home region. What about Ms. H, an immigrant to the United States with breast cancer? Ms. H is a 42-year-old single woman who was brought from Africa in 2023 to the United States by the UN High Commission for Refugees. They had a program to treat patients with different types of cancer. I actually cannot figure out if that program still exists. While she receives treatment at a cancer center, she has no family in the United States for practical or emotional or financial support. She profoundly grieves the death of her mom, who died of breast cancer in Africa before Ms. H moved here or was transitioned here. And she misses her children in Africa. Ms. H has a very marked history of untreated trauma from both political and sexual violence. By the end of my short presentation tonight, I'd like you to be able to summarize inequities in breast cancer burden in the United States and globally, and to be able to list 5 barriers to cancer screening and care among women worldwide, and describe barriers for breast cancer care, especially for refugees and other displaced persons in the United States and globally. Before I go any farther, I'd like to talk a little bit about inclusive populations and language. Our presentations and even the title tends to focus on women with breast cancer. And our evidence in our country is overwhelmingly based on white, middle-class, educated individuals classified as cisgender, either women or men, versus asking about gender identity. That doesn't work really well in our clinical settings and in our population approaches. We need far more inclusive language and classifications to recognize the intersecting diversity of the broad range of patients who identify as gender diverse in care and in research in both women's health, cancer settings, and community settings. So we need, as a social justice approach and strategy, to be a part of advancing inclusive participation in language and in our research, in our practice, in our education and training, and our advocacy around inclusivity of populations. So you'll mostly hear me refer to women, but I will try very hard to use more inclusive language. A lot of what I have to say today about inequities in cancer care in the United States and globally, we could probably make a good case exists for almost all cancers. Tonight, we're going to focus on breast cancer, partly because it's my primary area of expertise. I had ovarian cancer and colon cancer. Partly it's what I was asked to do. But frankly, some of this conversation is just as relevant to individuals and families and communities coping with other types of cancer. Breast cancer is, in fact, a global health issue. We see data from the World Health Organization. Breast cancer is the most common cancer among women in 85%. Listen to that, 85%. When do we get statistics like that? Or 157 out of 185 countries. Sit with that for a second. And I apologize, I meant to update this data. In 2022, over 2 million women were diagnosed with breast cancer. I can tell you that number's gone up, not down. With 670 deaths, now 670,000 deaths worldwide. That number hasn't gone down. And among marginalized population or minoritized population, that number's gone up. So I'd like you all to use the chat. I felt strongly that I didn't want to put you as individuals on the spot. So let me ask these 6 questions. And if you relate to any of them, you're going to answer yes. And I think Andrew or Kyler are going to summarize, Andrew, thank you, Dr. Van Orden, are going to summarize how many people of our, I can't tell how many's on with tonight, 18, 20, are going to summarize how many of you en masse said yes. So first, and wait until I get through all 6 before you respond. And I'm not going to be looking at your responses because I'm terrified I'm going to lose my slides. Do you treat women with breast cancer or individuals who were biologically assigned as women at birth, or trans men who with breast cancer? Do you have a family member with breast cancer? Do you have a colleague with breast cancer? Have you had or do you have breast cancer? Have you cared for an immigrant or a refugee with breast cancer? Do you advocate for better access to breast cancer screening and care? If you said yes to any of those, would you put that in the chat? And I would guess that it will be 98%, if not 100. Then we're going to give all of you a moment. Everybody done? Andrew, can you signal to me?
Sure. So far, about 10 have said yes so far.
Okay. Is that about half? About 60%?
Yeah, a little more than half.
Okay, 60%. So I was off. Okay. I wish I had time to ask you why you're attending tonight. Maybe in the chat, if you could share with us what made you want to attend this evening, besides that it's your standard social justice program. Why this one? All right, let's do a little breast cancer risk and treatment 101. And I'm glad I did this since not 100% of you said you have been related to this issue in some way. I'm not going to do a lot of slides on this, but I wanted to level the playing field because it will make later when I speak about these issues, some of this will be relevant. So what are the general risk factors for breast cancer? Well, first, while the rates of breast cancer are markedly increasing in younger women, women under 50 and under 40 in the United States and globally, actually, you're more likely to see older women, women over 50, over 60, with a diagnosis of breast cancer. Women in general are at risk for breast cancer if they're overweight, if their alcohol use is high. We have been saying roughly 4 or more drinks a week, not 1 a day, 4 or more drinks a week of any kind increases risk for breast cancer. I'll be interested to see if that data becomes more precise in the years ahead. Environmental exposures, I'm going to talk about that in a minute. I'm going to do a whole slide on that because this is something, all of these are areas that you, if you're a clinician or doing public health interventions, can do something about. Hormonal exposure, early menstruation and having periods for or menses for the longer part of one's life, a delay in the first pregnancy, less time breastfeeding, having no or fewer children. Inherited genetic mutations, and I want to remind everybody that these mutations may be carried by the father of your patients, and I actually have quite an experience of that in September, where the entire family history of breast cancer was entirely on the father's side. So roughly 5 to 10% of breast cancer diagnoses are related to inherited genetic mutations. You're more familiar with BRCA1 and 2. However, there are a very long list of, there's about 11 at least major genes. So I listed a few. CHEK2 is a particularly interesting one. You may see a family with a lot of colon cancer and then a bunch of breast cancer. Uh, did they carry CHEK2, not BRCA1 or 2? So your antennas should be going up. The BRCA1 and 2 are what we call founder mutations, and they're more common in Ashkenazi Jews in roughly 1 in 40 individuals. Some of us are Ashkenazi Jews and don't test for BRCA1 and 2, even in the presence of breast cancer. Perhaps carry a different gene that we don't know about yet, or it can be a false negative. Nonetheless, Ashkenazi Jews are more likely to carry the BRCA1 and 2 gene that are associated with inherited genetic risk. These genes place a higher risk for breast, ovarian, prostate, and pancreatic cancers. So multiple times in my career, I've had a patient with a family history of pancreatic cancer, and maybe someone else had breast cancer, or maybe not, but had a younger and younger distribution of cancers. Your radar should go up that that person needs high surveillance, high screening, and genetic testing. And what we're finally seeing is now people are being followed for early detection, not only of breast cancer, but pancreatic cancer. That was an awfully quick summary of genetic risk, of general risk factors for breast cancer. I want to take a second, though, and remind everybody about the environmental exposure, exposures that increase breast cancer risk. And this is an area where, whether it's a clinical individual, family, or you do population and community work, is really important. And you're going to see more and more discussion of this because it's probably one of many factors that is increasing the diagnosis of breast cancer and colon cancer in individuals under 50, in both and in women, and colon cancers in young and men. So you're seeing a lot of discussion. In fact, Yale has one of the top. Dana-Farber has one. I don't know what Yale. Dana-Farber has one of the top programs about younger adults with colon cancer. Here in Colorado, we have one of the top. There's one of the top programs for younger women with breast cancer. So take a look at this. So I mentioned alcohol because it changes estrogen processing. That is definitely a serious environmental exposure. But parabens, how many times do we need to talk to people about making sure they're not using hair products, cosmetics, moisturizers with parabens, vaginal moisturizers, vaginal lubricants, everything needs to be paraben free. The phthalates and BPAs in our bottles and in our food and our packaging. You'll see a much bigger focus on eating fresh foods, not eating processed foods, not eating foods where you have to open a package. We are kind of killing ourselves with, and obviously some of these packaging have let us have more durable foods, which is important in food shortage areas. But at the same time, we're increasing exposure. So and I just want to say something about radiation. In my practice over the years, I've seen people with childhood cancers come to me for infertility, but in fact, they had radiation and no one's ever put them on an early screening plan for breast cancers, and subset go on and develop breast cancers. So your radar should be up. All right. Breast cancer screening lines, they just changed. American Cancer Society ones are a little bit different. These are the USPSTF guidelines in 24. Bottom line is we're now screening people not below 50, but below ages 40, every 2 years, unless somebody has risk. Then we want to get them into screening, or if they have dense breasts, they may be not just having mammograms, but having ultrasounds and MRIs. And certainly really a radar for individuals. And if somebody has a high family inherited risk, for example, diagnosis of breast, pancreatic, ovarian cancer in younger subsequent generations, that should catch your eye, that they should be referred to a high risk screening program. So In our country, when we're privileged, we have comprehensive cancer centers that are patient focused. We have multidisciplinary teams. They're team based. Usually there's a navigator that helps people coordinate all their aspects of their complicated care. We help people understand this is really chronic disease management now, more like diabetes. We have a lot more integrative approaches. And so breast cancer treatment, depending on all kinds of factors, can include surgery, radiation, anti-hormonal therapies, chemotherapy, targeted therapies, immunotherapies, probably gene therapies in the future, etc. But that's not all. Survivorship resources. And when I first started to get interested in inequities in cancer care, I started asking my question, I'm a psychologist. I've spent 40 years working on psychosocial aspects of cancer experience. Well, what do people around the world get on that right category, much less on the left? And we know that survivorship resources can include any number of these areas. Exercise and good sleep and amazing nutrition are associated with better outcomes. But certainly started to wonder what happened when you were from a minoritized community or an immigrant or a refugee. I first started to ask this question during the Syrian refugee crisis, and I was looking at a group of women in like the news and was like, well, I know a subset of those women have cancer. What's going on with their care? And that's when I started to become interested in this pre-COVID. Just in the United States, about 1 in 8 or 13% of women are diagnosed with breast cancer. We have over 300,000 new cases of invasive breast cancer. It's the second most common type of cancer after skin cancer in the United States, and it's the second leading cause of cancer death. And I think you probably all know that lung cancer is the first type of cancer of cause of cancer death among women in the United States. In the United States, nonetheless, we see marked disparities across racial and ethnic groups in breast cancer outcomes. So while the base rate of breast cancer among, for example, Black women in the United States is about the same as white women, they face a higher mortality rate. We also see a rising incident in breast cancer. Some of that's because we have better detection and more effective treatments. But we see, as I've mentioned, an increase in breast cancers among women under 50. We see an increased rate among breast cancer in Asian women and definitely among Black women. So I wanted to give you kind of a quick 101, but I really want to move towards disparities now and see if we can have a deeper understanding. It'll take me about 10 minutes and then we're going to open the conversation. So I've had that slide of breast cancer awareness on the left that says 32 cents forever. And I thought, gee, well, we don't have 32 cents forever stamps anymore. So in 2014, the first class when there's a second one that came out. And I wanted to remind everybody that we can indirectly support breast cancer research and care by buying forever stamps that are with the breast cancer logo. But let's talk about disparities. So in the United States, Black women are more likely to have aggressive forms of breast cancer, more likely to be what's called triple negative, TNBC, triple negative. They are ER estrogen negative, they are progesterone negative, they are what's called HER2 HER dash 2 dash new, NEU. I'm not going to explain that. All negative, all of that is associated with worst outcomes, poorer outcomes, more aggressive cancer. And consequently, darn it, Black and Hispanic women actually have higher mortality rates in the United States. You're going to see a much greater focus on understanding the breast cancer in women under 50 in the United States. You hear about it in the media. We have a role as psychologists in ensuring that our younger patients not only are maximizing their health and behavior, but that they're getting good screening. Well, what about disparities globally? And I didn't want to drown you with stats. I didn't think that was helpful. I want you to leave with kind of the general understanding that we have a global problem here with disparities in cancer care, not so much the stats. And also, we don't have enough time to do a deep dive. So as WHO pointed out to us, breast cancer is the most common cancer worldwide, and it's the leading cause of death among women, and it's disproportionately affects women in what we call low and middle low income countries. So if you look at the 5-year survival rate by what's known as the Human Development Index, it's a public health term. If you look at survival in high income countries, like big data, like in our country or Japan, Australia, Sweden, really 90% are probably living 5 years if they don't have stage 4 disease. But when you move to low and middle countries, the 5-year survival takes a marked decline. In India, South Africa, if you looked at the increase in breast cancer rates in Africa, we see a marked increase in like 5% increase in breast cancers in Nigeria, in Malawi, in the Eastern Cape, in Zimbabwe. This is frightening data. 5% in a year is a huge increase. So I literally pulled this from Google AI because it was the most succinct for you. What are some of the key drivers of the increasing incidence? Well, poor countries having lifestyle that's more like ours, which isn't so good. More booze, more obesity with more food available, an aging population. Because I've said 10 times now that we're seeing an increase in breast cancer in younger women, but breast cancer still we predominantly see in older women. These lifestyle factors, lack of physical activity, alcohol again, environmental exposures, and then improved detection, and also later having pregnancies at a later time. What I didn't like about this list is it didn't really talk about the environmental exposures, the food packaging, the processing, the chemicals that we are basically killing ourselves with. So I wanted to show you a couple of model programs of what countries are doing about this. Um, in two ways. One is access to breast cancer screening, whether it's a mammogram or that's an ultrasound machine on the upper right. That's just an MRI, but when you have a breast mammogram, you're lying face down and breasts kind of hang below and the imaging comes in. It's kind of hard on the sternum, but I want you all to see this, especially gentlemen who may not have had these procedures, to know that we want to actively prepare patients for these procedures to improve outcomes. As a health psychologist, our field started demonstrating the active benefits of preparing individuals for medical procedures to improve outcomes. So any of these procedures, we want to actively improve them, improve preparedness for them, help patients go with questions. So, and also programs to improve the continuity of breast cancer treatment and survivorship, whether it's surgery, that's what a cancer radiation machine looks like. Patient lies flat, and that thing on the top moves around them. The patient doesn't move. Whether it's any number of medications, chemotherapy, immunotherapy. So what are some of these barriers? Well, simply put, the historical and ongoing gender and racial bias, difficulty accessing services of all kinds, the biomedical and the psychosocial one, especially in underserved communities, in individuals where there's displacement, fires, coastal flooding, rural and frontier communities. I live in Colorado, so we have to say rural and frontier. Frontier starts at about, oh shoot, I can't remember now if frontier is 10,000 or 12,000 feet above, 10,000, I think. Health insurance. When Dr. Clark and I first started talking about this, we really anticipated a health insurance crisis in our country, which we're seeing. All too many people and more people are going to have no insurance, or they're going to be underinsured. Changes in Medicare eligibility. Cost of plans under the Affordable Care Act, Medicare, private health insurance plans that are becoming astronomical. High deductibles and co-pays resulting in people actually just avoiding or delaying care. Healthcare related debt is a huge issue in our country. More and more individuals who are not going to be insured at all, and certainly homeless women and children who are maybe less likely to have insurance. And I can't not talk about the fact that we're likely to have reduced and overwhelmed healthcare services. We already do in primary care and cancer care. And this is not only true for inner city, but in rural health services. I'm very worried about rural facilities closing because of changes in Medicaid. I don't know how some of them are going to sustain their services as Medicaid refunding diminishes. But what about displacement? I just threw in a couple of examples without even looking some up. Hurricanes in Puerto Rico and North Carolina, fires in California and Colorado, floods in Washington, Oregon, Texas. What happens if you're in the middle of cancer care and your facility or your home doesn't exist anymore? And you have to move. And for immigrants and refugees, all too often unstable living situations, language barriers, financial barriers, the stigma, um, other priorities when you're an immigrant or a refugee across the world, including the United States, and certainly changes in immigration policies in the United States and other countries. We have clearly, and I'm not going to politicize this, I'm going to talk at an individual level, the deportation of immigrants, many of whom are in all kinds of medical treatment, and changes to immigration and asylum rules in the United States and in European countries. What about refugees, where I started my interest in this area? Well, by definition, there's unstable living circumstances and displacement. They're unable to access or continue in care. Cancer care is all about continuity. There's endless blood work, infusions, accessing meds, taking meds, the management of symptoms for the long term. It takes continuity. And then unhealthy living environments when someone's a refugee. They may not have food or insignificant, infrequent food or shelter or exposure to sexual violence. I just wrote down 4 countries without even doing a search, but these 4 countries came to the mind very quickly. So again, I did want to talk about model programs. WHO, I'll talk for 5 more minutes and then the stage is yours. I really wanted to talk about this program. WHO has brought together stakeholders around the world and across sectors to reduce breast cancer by 2.5% per year, which listen to this, over a 20-year period would save 2.5 million lives. Remember, I just said that in some African countries, rates of breast cancer were going up 5% a year. Here's the UN goal to decrease that, and look at the lives saved. Staggering data. They have 3 major strategies: health promotion and early detection. I think that includes an educational component in marginalized communities. Timely diagnosis to remove this delay if you have an earlier diagnosis, your long-term survival is much more likely to be improved. And comprehensive breast cancer management. So they work with governments, with communities to improve detection, diagnosis, and treatment, and to really bridge these inequities and recognize that we actually need to have systemic improvements at so many levels. A couple of examples, and again, this one I did just pull from AI, of amazing programs in Africa that if you want to read more about, you can. I highlighted these. I'm not familiar with these programs. There are some in Europe I am more familiar with, but I like them because they were community-based. And we have similar programs in the United States, and I'm going to show you some of those resources when I get to a resource slide later. But I thought some of these programs were really interesting when I just did a short overview, and I wanted you to know about them. So the last few slides are, what does this mean for us as a social justice crisis and a social justice imperative? We can take active steps to reduce breast cancer disparities in screening, in care, in improving patient well-being and outcomes, and we can reduce the rates of new breast cancer diagnoses if we really look at those risk factors. So I want to borrow the WHO goals that our job is to empower women in their care, to build individual and community capacity, and to ensure that all of our patients and our communities have outstanding care. So that means any one of us could work at an individual level with patients and families, We could work with communities. We could work with health systems. We could work at the local, state, and federal level in policies, and we can work at the global level. Well, let's start at the patient level. For one of the things that by coming here today, for those of you who see patients or develop programs, you can start with better education, helping people understand that many of the risk factors are modifiable, that we can empower patients to improve their self-care. I get very irritated when I am told that by my physician and healthcare colleagues that the patient said, I'm not motivated to take care of myself. That is not an endpoint. That is a symptom. Is that because they're depressed? They're dealing with trauma? They don't have the resources. They don't know where to go. They live in an environment that's too dangerous. Not having motivation for self-care is a symptom, is a place to start a conversation, not to finish a conversation. I know I'm on my bandwagon here. I'd like to actually write do a huge presentation about this. So please, when you hear that, it's an opportunity, not an endpoint. It's not a character defect. So we are in a great way through motivational interviewing for deeper understanding of the cultural and relational context of our patients' life to understand how to support their self-care, to reduce their breast cancer risk, to help them engage in breast cancer screening and to stay in treatment, to help them know how to access care. And I'm not going to go through all these, I just did. But really, in a clinical interview, are you getting detailed information about these issues, which aren't just related to breast cancer, but any number of physical conditions that we can actually promote prevention and health promotion? Make sure you're referring patients. Make sure you're listening to patients. If they're like, hey, I told my GYN or women's healthcare provider that my breast doesn't feel right, but they said, you're too young. You intervene right away. Patients, we know our bodies. Everybody on this call knows our bodies. If someone feels something different, they need to have another provider. They know their bodies. And if it's I can't tell you how many patients, like it took 3 visits before they got a biopsy. And of course, they had a breast primary. Now, most lumps and bumps are not breast cancer. But when a patient says, if they're concerned, support that. Listen, listen, listen. And especially if it's a woman of color, an immigrant, a refugee, somebody from the LGBTQI or disabled, or somebody with neurologic differences, support them in accessing care. And pay attention to that family history. My radar would go up immediately if somebody said, yeah, my father just died of pancreatic cancer. You should be doing like when you do family trees, it's an opportunity. Okay. So at a different level, we can work with hospital and health systems. We can work with community groups to improve rates of screening, to decrease stigma, to have much more educated communities. Can also participate in local and state coalitions on cancer care. I haven't been able to do this recently, but for about a lot in 24, and I'll start again now, no, 25, and now in 26, I attend the Colorado Cancer Coalition monthly calls on breast cancer. Your state one is Connecticut Cancer Partnership. I'd love if you put in the chat if any of you participate in that. I told you in the United States we have tons of programs, and we do. So when you get these slides, and I'll send them tomorrow without the pictures, you'll have a nice list. And of course, Connecticut, you have your own wonderful resources as well. But these are some national resources, and I tried to make sure you had some that really address resources for cancer care. Some of them do referrals. Some of them will provide financial help. Some of them will come out and I don't have American Cancer Society in here, but they have programs. They used to send someone out to mow the lawn of one of my patients who no longer was able to, and they took care of her transportation. And so some of these organizations it's not just support, they have financial resources as well. There's wonderful programs in Europe and in Africa. And Sharsheret started in the United States, I believe, but also has an Israeli chapter. The High Commission is not specific on breast cancer, and they had programs for refugees from Afghanistan, Syria, Ukraine. I could not quite figure out if this program still exists, but I want to, because I don't know what's going on now, but let me just say our current posture towards international health and well-being will hopefully change in a different administration. And hopefully we will support that moving forward. But I wanted you to know about it. And the High Commission would collaborate with the Union for International Cancer Control to bring programs. Europa is an impressive program, and some of these programs in Europe deal globally with other countries. So let us all work through a call to action to reduce disparities in breast cancer incidence, screening, care, and outcomes across the world. We basically have a call to action. We have a social justice crisis using this example, and we also have an imperative to ensure that everyone we serve has better access to care. I hope this is what you had in mind as a place to start a conversation. I'm going to stop my sharing. I hope it wasn't too basic. And the floor is yours. I only have 12 minutes, but was that helpful at all? Was it what you had in mind? Any surprises?
It was wonderful, Dr. Coons. Thank you so much, specifically when you talked about the relationship between pancreatic cancer and colon cancer and breast cancer. Those are critical for us to know, and also the strategies that you shared about how to deal with patients. So we are looking forward to hear your comments, questions about tonight's talk.
Thank you so much. The floor is yours. Surprises? Don't agree? Do I know why Connecticut apparently has an especially high rate of breast cancer? I do not. Can someone answer that? I've not looked at your statewide data. And is that across all ages, all stages, all types of breast cancer? Does anybody know? The place to look is the American Cancer Society facts and figures, or that Connecticut Cancer Control group I just told you about. That's who does the state plan, your state plan. It's called something different in each state. I think that was the partnership. Anybody know your data in Connecticut? Maybe someone on your committee, and I can try to look at this next week. I can try to take a look at, see if there's some reasons that would account for that. Connecticut is not only an urban but a rural state. You're not a frontier state, obviously. You actually have some coastal, a part of a significant coastal footprint. You have an economically profoundly diverse state, from the wealthiest to the poorest, the poorest. I don't know why you have higher breast cancer rates. Did whoever asked that, do you have any information on why? Could it be higher rates of screening? Good question. Is Connecticut's population older than other states? Do you have a disproportionately higher disproportionately higher number of individuals over 50?
Good questions. We're going to have to do some research on that. We certainly know Florida or whatever, where, a lot of retired folks are not moving to Connecticut from other places, but yeah, that is curious.
I don't know the answer, but let's learn about it. Hey, there's one thing I didn't say that I want to point out. And we're going to actually do a program at APA in August about this, when psychologists have cancer. And anybody who's diagnosed with cancer, you ever want to reach out to me, you're welcome to. I frequently consult with other psychologists and healthcare providers facing a cancer diagnosis. Because we're going to see breast cancer, colon cancer, pancreatic cancers in younger individuals, we are going to have colleagues, whether clinical or teaching faculty or whatever professional setting. We're going to have graduate students, and we're going to have young colleagues and mid-career colleagues who are going to have cancers. So just a heads up that this is going to be even more important for you to know about. We're going to do a program in August, if it's accepted, about this issue. Yeah. What else? Anything surprise you? Do you think this is a social justice issue?
Well, I loved when you talked about what any clinical psychologist, practicing psychologist can do when assessing a new patient or listening to a patient. We do have here in Connecticut, although it's been postponed, a universal medical records system, and there's been, a lot of concern about entering data into that system, which we don't have to do yet. That was postponed, and there's going to be more work on that. But you make a really good case for how we as psychologists can gather health information that would be helpful to the other medical providers, even if we're not directly consulting with a healthcare system, et cetera, but doing it more as a team approach and giving information that could be helpful to the other healthcare providers who would be able to see this general information with patient permission. That was one of the issues that we're having to deal with. Yeah.
And if you're not integrated in a health system and you're seeing people more in an independent setting, hopefully you're, as a standard of practice, writing a very short consult note with the patient's permission. When you're doing a developmental history, including a family history, you're obviously asking about not just psychosocial stuff, but health stuff. Your radar should go up. And in a note, you can say, among the several reasons you're treating them, you've also referred them back to you to discuss their family history across multiple generations with a cascading age at diagnosis. And document it and send it and empower the patient to go back. I can't tell you how many times in my career I've had to support a patient to go back to a provider. And, after the second time, it's like, nope, you're getting another provider, another provider. Um,
Dr. Coons, I think you made an important point there, and more broadly, find that often it's important and helpful to do some coaching with people with that, just how to approach their medical providers and some ways to do that and to deal with some of the anxiety and what's good in getting care. I have a couple of questions for you. One is that there's a large, at least I'm in the Danbury area, and there's a large Hispanic population in other areas of the state. And I wonder if you have any thoughts about, you didn't mention about, Central and South America and the displaced from that culture. We have large populations that are from there, at least until they will get deported. Dealing, if there are any cultural factors or specific factors to that. Another thing I'd like to hear your comment is to a little more broadly than just the breast cancer, to look at issues about as we advocate to have a little more bang for the buck of what's good to advocate and be aware of to broaden treatment for other cancers. I have a little personal investment in this. My wife has been treated for lung cancer, and she's among the 20% of people with lung cancer who have no history of smoking. And it was only discovered because thankfully she's a bit clumsy and she tripped at home and fell onto a dehumidifier. And as they were checking for rib fractures, they noticed that she had some nodules and it was stage one. And they don't, in order to be, although with breast cancer, the standard of care is often the screening, the regular screening. In lung cancer, it's only if you've had a 20-year history of smoking a pack a day and you're over 50. That's when they kick in for routine screenings.
So in lung cancer now, there's several centers around the country that are like small nodule clinic, basically. I know there's one here because actually it came up personally, and it's like, so there are a bunch of centers across the country that will follow people with small nodules that didn't exist a few years ago. And like, let's make sure we're catching these things early. Same with pancreatic cancer. So, and I'm sorry to hear about your wife, and we wish both of you well in a very long.
Doing well, thankfully.
Good. So I
Getting
want to
caught
go back
early.
a couple seconds about your question. Yes, I did not sort of put the South American data. I was trying to kind of give you examples, and I apologize if that seemed insensitive or as an oversight. So as in any cultural group, are there stigmas about touching and let's broaden the conversation, touching oneself? Having exams, but without a male partner in the room. There are certain cultures for whom that does not happen, and not both culturally and as a issue around relational power and control. There are individuals. Uh, One of the things that when you said Central America, that I was thinking about is how diverse all of these communities are. And there are Central Americans who are Ashkenazi Jews. They grew up in South America, but their families, their grandparents were immigrants during the Holocaust, or they were immigrants from any number of other countries way before that or since then. And so to be careful, and I'll never forget this. I used to meet all these individuals from in the East Coast, from Cuba and from Puerto Rico, and a subset of them were all Jewish. And I'm like, okay, not Catholic. I had to quickly like abandon my assumptions. And one of them came from an Ashkenazi Jewish family. And one of my closest colleagues in Philly was an Argentinian Jew. And her family absolutely were Ashkenazi from Europe and emigrated around the time of World War II. So, Dr. Stern, the reason I'm belaboring this is it's really incumbent on us that we not make any assumptions about anybody we have in our presence. And we ask them about their family history. And just because they're from South America doesn't tell us a whole lot about their religion, their genealogy, their biological genetic inherited risks. And so ask questions. The other thing I want to say, and Dr. Ward Zimmerman will understand this as my fellow, a couple of you are health psychologists on the call. Historically, when I had a patient in front of me, and now even on a Zoom call, say, you know what? You sound terrified. You kind of look like a deer in the headlight, and you have a big visit tomorrow with the oncologist. Would you like some help getting ready for that visit? I want to invite you to bring someone with you to take notes. You can use a translator if you need to, but we really need a mature, not needy person, mature family member. The family member should not be the translator. Um, to go with that person, but I actively want to prepare them for that visit. So I might say, um, would you like some help getting ready for that visit tomorrow? Would you like to generate a bunch of questions? Because at that point they're shut down. And I've never had a patient say no. And I said, well, how about you grab a piece of paper? If they were sitting in front of me, I'd literally hand them a pad of paper and a pencil or a pen, and I literally might sit next, pretty close to them, a little more close than I would normally in kind of therapeutic space. And we go through questions and get them ready for a visit. And so that they leave that visit. And of course, I'm helping them ask questions through a very educated, privileged lens that there's no reason they would know how to ask. And they come back both sometimes scared, sometimes way more reassured, but they feel more empowered. And that's what I'm looking for. And I'm looking for them to take that anxiety, take any of the cultural beliefs and bring them into encounters with their healthcare system. And even say, you know, Dr. So and so, I kind of view this differently. Or here's my worry. Or am I never going to be sexual again? Am I never going to have kids again? I don't know about losing my breasts. Whatever the example, I'm just throwing out examples for you. So there are good South American programs as well. And I know we're running out of time. I think I have a pretty serious pit in my stomach when I think about women who have been deported in the last year back to South America in rural communities with substandard breast cancer care. That makes me sick, but it makes me empowered too for us to have these conversations and to do what we can, whether it's financial contributions or working with communities that are here, um, that we have to stay empowered. So, Dr. Stern, I probably could have answered your question over about 3 hours, but those are some high notes. One last question, then we'll end. You don't have to agree with me, by the way, either. The world according to Helen's not necessarily the only world.
We have a question in the chat. Lena asks, the program's working with refugees to get treatment. How can clinicians provide support the best way possible? It's not only hard to deal with the cancer itself, but also being away from support systems that can make it difficult to cope.
Mhm. In the United States, you could volunteer if you don't speak the language, have a translator with you. You could donate. You could, if your finances allow it, donate even more, establish programs. You could write a grant. I'm not for the next couple months, but one of my colleagues knows I would really like to write a grant for them for breast cancer care for immigrants and refugees. I'd like to deepen an existing program. That place brings patient has some of the women from the UN program for refugees. I would like to get them another grant. Well, I can't see their patients anymore for other reasons, but I sure could write them a grant. I'm not sure right now about how much community money there's going to be for those grants, but I got my eye out. Most of us on this call really could write a foundation grant in our sleep, frankly. So volunteer, work for them, see their patients, do some pro bono work, give money, bring voice. That's how I started getting into this. When I started asking these questions, then I started presenting to deepen my expertise and use my privilege to give voice, to give um, visibility to individuals who don't have our power or our privilege, to speak to the disparities, to take this from a social justice crisis to a social justice imperative that we can impact.
Thank you. I will now read the closing remarks. Thank you for the wonderful talk, and thank you all for joining us this evening. We are excited to announce that our next event will be held on February 19th with Dr. DuBois Walton as our featured speaker in honor of Black History Month. I want to emphasize that together we are the facilitators of change and empowerment for individuals and our community. Regardless of the amount, your generous donation to the Social Justice Speaker Series helps ensure that education and awareness remain powerful tools for making a difference in our community. The donation link and mailing address are available in the chat if you would like to support us. For those registered for the continuing education credits, I invite you to complete the CE evaluation link to receive your certificate, which is now being added to the chat. Once again, thank you so much for joining us this evening, and we hope to see you next month.
Thank you, everyone. Thank you so much, Dr. Coons. That was a fantastic information and experience for all of us. Thank you all for your participation. Looking forward to seeing you in February. Bye, everyone.
Good night, everyone. Thank you so much.
Thank you.
Thank you all. Take care.